So you look at both pH and CO2. If the pH and CO2 are both in the same direction, if they both are increasing or if they both are decreasing, then the problem is metabolic. The problem is metabolic. If they are moving, the pH and the CO2 is moving in opposite direction, then the problem is respiratory. Now coming toward diagnosis of this ABGs. Now if you see the pH. Hello, assalamu alaikum. This is me, Dr. Jahangir, and you are watching me on my YouTube channel, that is Dr. Jahangir Khan. आज हम एक common ABGs के बारे में बात करेंगे. So this patient presented with the drowsiness. The patient is a smoker having 40 year history of smoking. So from this ABGs, what is your diagnosis? So the first thing is you look to the pH. Now before going into the detail, please do watch my channel regarding the ABGs. So I have explained all the acid-base disorder. That is 22 minutes video along with compensation formulas, MCQs, mixed acid-base disorder, and there is another video that is given, the link is given in the description below. How would you proceed in the metabolic acidosis? Well, sorry for the quality of recording. If the recording is not of good quality, agar iski quality kharab hai, I'm sorry for that, because the camera stability was not good initially. तो जो metabolic acidosis पे जो मेरी वीडियो है तो उसमें थोड़ी वो गड़बड़ हो सकती है. तो इसमें आप पहले देख लें pH को. So the pH is acidotic. The first thing, the pH is acidotic. Next thing is you look at the CO2. So you look at both pH and CO2. If the pH and CO2 are both in the same direction, if they both are increasing or if they both are decreasing, then the problem is metabolic. The problem is metabolic. If they are moving, the pH and the CO2 is moving in opposite direction, then the problem is respiratory. Now coming toward diagnosis of this ABGs. Now if you see the pH is decreased, you look at the CO2, that is increased. So the problem is respiratory. The problem is respiratory. Without looking into the bicarbonate, you can see, you can diagnose this patient. pH down, CO2 upward, so the problem is respiratory. And the pH is down, CO2 is, this is called respiratory acidosis. This is called respiratory acidosis. Now this is acute respiratory acidosis or this is chronic respiratory acidosis. The answer is chronic respiratory acidosis. Chronic. Why chronic? Because if you look at the bicarb is increased. In acute respiratory acidosis, the bicarb is normal. That is 22 to 28 within the limit. If that is more than 28, it means this is chronic. So the problem is chronic. So it is type 2 respiratory failure and this is chronic. Now the next thing, it is compensated or not? The answer is partially compensated. The answer is partially compensated. Now what is the cause of the CO2 detention in this case? If you see the bicarb is up, this is chronic type 2 respiratory failure. But the pH was supposed to be normal, because in chronic type 2 failure, we know that the pH is normal because of the compensation, provided that the patient has stable COPD. So over here, the type 2 failure cause, number one is the COPD, number two is the main problem that the patient comes to your ER, you give oxygen, the person become unconscious. The second problem is you can see over here oxygen. You are giving more oxygen. And now you can see over here this. Can you appreciate this saturation? Do you think you need 98% saturation in a case of type 2 respiratory failure? The answer is definitely no. We need 88 to 92%. Now what are the target saturation in type 2 failure? The answer is 88 to 92. In type 1 failure, target saturation is 92 to 95, and in pregnancy that is 95 to 97. Oxygen is a drug. If you are giving more drug, there is more side effects. It produces reactive oxygen species. It can cause destruction, and it can cause problems. So controlled oxygen. So the cause here is the COPD. The second cause is the high oxygen. So you decrease oxygen and repeat abgs after 2 hours and look at the pH and the CO2. Because there is a hypoxic drive, there is a term that is called hypoxic drive. The COPD patient, their respiratory center is driven by hypoxemia, the low oxygen. There is low oxygen, the respiratory center is stimulated and they breathe and they wash out the CO2. Now when you give high oxygen, this hypoxic drive that is removed and the person retains CO2. The person retains CO2. So this was a simple case of abgs. Most of the time in the ER, in the OPD, in the ward, we give high oxygen. Now the second most common problem is when you nebulize with oxygen. The COPD patient are those patients who are at a risk of CO2 retention. When you nebulize with oxygen, they would definitely go into type 2 failure. So my request is, do not nebulize with oxygen source, nebulize with nebulizer machine, and keep the target 88 to 92%. In COPD patient, in obstructive airway disease, in those patients who are having stroke, who are unconscious, and who are these are the patients who are at increased risk of CO2 retention, who are having obesity hypoventilation syndrome, who are having restrictive lung disease, who are having ascites, who are having abdominal distension due to any cause, who are having muscle weakness, who are having chest deformities, who are having neuromuscular disorders, who are having brain occupying lesions. These they are running on hypoxic drive. When you give more oxygen, they will retain more CO2 and that will lead to CO2 narcosis. Thanks for watching. Please do subscribe my channel and press the bell icon so that you can get notification of my videos.